Well, first of all, thank you very much. There's a hidden, well, not a hidden agenda. There's an agenda to this meeting. So I'm about to defend this proposal for Wellcome Trust in about 2 weeks' time. And so, although I've conducted clinical trials, and we've conducted clinical trials in improving adherence in anti-epileptic drugs, in improving communication with women's groups in Kilifi, this is quite a major step in terms of a trial which will be across 2 sites. And it's also quite a complex intervention. So to give you some of the background, so I'm a pediatric neurologist by training, and my interest is in neurodevelopmental disorders. And by that, I mean autism, attention deficit disorders, cerebral palsy, intellectual disability. I'm not going to address dyslexia and epilepsy and seizures. And I've grouped these all together mainly because they share similar genetic polymorphisms for susceptibility. There's similar biological and environmental risk factors, for example, prematurity, birth asphyxia, and such like that are related to autism, cerebral palsy, epilepsy. And even environmental factors such as lead, for example, are associated with autism and attention deficit disorder. They often occur together, so if you make a diagnosis of autism in a child, the child will often have features of attention deficit disorder, will have intellectual disability, a third of them will have epilepsy. Across all of those disorders, what the parents complain about when you see them in clinic are their behaviour and lack of communication. So these 2 deficits cut right across all of these disorders. And in fact, for example, the parents of children with epilepsy will often be much more worried about the behaviour than the seizures, because they're causing much more disruption within the family. And finally, in Africa, the stigma associated with them are very similar. So a lot of these disorders, autism, epilepsy, are attributed to traditional causes such as witchcraft, spiritual causes and such like. And also the economic impact that they have in poor communities is also similar. And so that's why I'm grouping together a fairly heterogeneous group of disorders together. And this table just really illustrates the comorbidity associated with each of these disorders. So, for example, if you have attention deficit, almost 6 to 20% of them will have autism. If you have cerebral palsy, you'll find that attention deficit disorder occurs in about 4%. So although these are relatively small, taken all together, they do represent a conglomerate in terms of the prevalence of the comorbidity associated with these disorders. So the core difficulties, as I've already mentioned too, are behavioural, disruptive behaviour, and communication difficulties. And so by disruptive behaviour is making it very difficult to manage the child in home, in the family. And so the parents spend a lot of time, effort, and also cost trying to manage that. So they can't leave the child alone. The child can't partake, for example, in rural Kilifi. They can't be left to go and look after the goats because they will just wander off and the goats will just wander off. And so it has quite a significant impact in many of these societies. And both of these core difficulties are very prevalent right across all of these disorders. So the program of work that I'm proposing to do over the next 5 years in Kenya consists of 3 components. I'm actually just going to discuss the last component. So there's a birth cohort, which is to look at premature mortality associated with neurodevelopmental disorders, and also to try and develop screening tools to be able to pick them up early. There's cross-sectional surveys to look at the burden in terms of the prevalence, risk factors for these disorders, and also both of those cohorts, the birth cohort and the cross-sectional surveys, will allow us to work out the mortality associated with these disorders. But for this morning, I really want to concentrate on the intervention, and just to emphasize the fact that the cross-sectional surveys are going to identify a group of children with these disorders. And so one of the imperatives is that can we do something about them? And that's what the intervention is really about. So for an ideal intervention in resource-poor areas, ideally, we don't make it, often you don't have the necessary expertise to make the diagnosis. So the psychiatric nurse sitting in a clinic is going to have difficulty trying to differentiate between attention deficit disorder and autism, or intellectual disability and cerebral palsy in many cases. And so you want to have an intervention that you can use across a wide range of conditions. Clearly, it's got to be effective. I work in low resource areas, so it's rural Kenya and informal settlements in Nairobi, so it's low cost. The intensity of the intervention has not to be too onerous, so we can't use therapists to give thousands of hours of therapy in order to try and treat the autism. It's got to be something that is not going to require a lot of time, because the parents just don't have the time to do so. Clearly, it's got to be sustainable in that we want it to continue onwards, and it's got to be scalable so that we can actually put it up into large communities and get it, the Ministry of Health involved. And so there was a recent review by the World Health Organization, which came at a convenient time because they did a very thorough review. There are really three major areas that we could have intervened. One is the behaviour analytical techniques, the ABAs, which are mainly used for autism. The problem there is that it does actually require thousands of hours of intervention. It requires qualified therapists, and it is just inappropriate for low resource settings. The cognitive rehabilitation type therapy is very useful at addressing communication and language and development, but it doesn't specifically address behaviour, which is probably the cardinal thing that the parents are complaining about. So we are left with the parent training interventions, and out of that review, only two really came out. That was the Stepping Stones PPP, which is the positive parenting program, and a clinical best-based individual parent. This last study by Varma was actually conducted in India. It's got a good effect size, but the problem it was on a one-to-one basis. So if you want to try and scale it up, you'd find it very difficult to do it on that basis. So we've actually plumbed for the Stepping Stones PPP. Not only can it be committed into groups of family or groups of parents in order to scale it up. The program is 20 hours over 10 weeks, so it's doable. And the effect sizes in this review, or the ones that they accepted, were quite reasonable. So the two sites that we're going to do this conduct these trials are in the informal settlements in Nairobi. So it's Korogocho and Viwandani. These are essentially between industrial sites, so they've got big industries on either side, and they're where the drainage areas are, where all the effluent comes down into it. So there's very poor sanitation. They are a lot of overcrowding, and generally what happens is that people move into these areas from rural areas looking for jobs, and then once they've got work and been able to get cash, they then try and move out of the area because it's not a very pleasant environment in which to live. And then in Kilifi, which is down on the coast of Kenya, just north of Mombasa, which is where we've been working for the last 25 years. And so we know that area well. Both of these are demographic surveillance sites, so they have censuses which have been conducted 1 to 3 times a year. So we have an accurate estimate of the population, but more importantly, we are able to follow up. In both of those areas, we've mapped all the households and all the individuals in the household. So in terms of trying to follow up a cohort in a clinical trial, we're able to follow them up closely by the repeated censuses. There are some quite significant differences between Kilifi and Nairobi, as one would expect between a rural and an urban environment. In particular, Kilifi is much larger. Outward migration rate is about 21% per year, so people are moving out there fairly quickly compared to Kilifi, which is about 9% per year. So for retention of a cohort, it's actually quite it's an important consideration. And then there is quite a difference in socioeconomic status. So 35% of people in Nairobi are under $2 per day, while in Kilifi it's over 70%. Kilifi being one of the poorest areas within Kenya. The other advantage about working within the demographic surveillance system is that we have community advisory boards, which help with sensitization of the community, and particularly in regards to interventions and what's going on, and are able to give feedback in terms of the problems that might be encountered. So that infrastructure is already set up, which makes it an ideal place to conduct these sort of trials. So the cross-sectional survey is going to be of about 13,000 children in Kilifi and about 7,500 children in Nairobi, both in ages between 5 and 9. for the epidemiological basis. And it's from these surveys that we will identify the children and families who will go into the clinical trial. We're going to use various screening tools that we hope to get the sensitivity up to about 80%. We've already done quite a lot of work with the 10-question questionnaire we've used previously in Kilifi, and we're just refining it to try and pick up autism, attention deficit disorders with the neurodevelopmental screening tools and the strengths and difficulties questionnaire. So what is the Stepping Stones Triple P, which is a positive parenting program? It's been specifically designed for children with disabilities. It was designed in Australia and Queensland. It has been shown to be effective at reducing behavioural problems and improving communication difficulties. The intensity, as I'll show you, can vary. It's particularly targeted at parents, so that means that you empower the parents, and also there is evidence to suggest that it is actually sustainable, not only from Australia, but also from North Carolina and the States, and from some European countries. And it can be scaled up into communities. And so these are the levels at which the system can be delivered, from a general communication strategy, which is across the radio, newspapers and such like, to try and improve parenting, to level 5, which is a very high intensity family intervention normally associated when the parents have mental illness as well. We're going to focus at level 4, which is you can deliver in groups of 5 to 10 families, and it has been shown to be effective. This is level 4 down here, and these are the effect sizes that occur. These are relatively small studies that have been conducted, relatively small sample sizes, but the effect sizes are quite reasonable. So the lowest one is 0.148, but it goes up to 0.7, which is actually a really good effect size for an educational intervention. So we feel confident that if it does work, that we'll be able to show a difference in that respect. We have done some pilot work in the informal settlements with the Triple P program. We know that it's culturally acceptable from our pilot work. We don't expect any major barriers. The barriers that have come up are in terms of attending the sessions for training, but it does seem to be culturally acceptable. So the Triple P has 7 core principles about positive parenting. 5 of these are really general principles about parenting. The 2 in yellow are the ones that are very specifically targeted at families with children with disabilities. So adapting to a child with disability, what you need to do in home environment in terms of management programs, and also being part of a support community. So in many places in Africa, if you have a child with disability, you tend to hide the child away. So because of the stigma attached to it and the fact that your family, if it was let known, then your family would be considered to be involved in witchcraft or superstition or such like. And so a lot of these children are actually, so we find children with autism, for example, which are chained to trees or beds or whatever, and left there because the parents have got to go out to work either in the fields or to find work in Nairobi. So they're often completely hidden away. It's only when you start doing house-to-house surveys that you actually are able to detect them. So it has 25 strategies which are listed here in 4 major groups. 14 of these strategies encourage child development and are fairly generic, and 11 of them are particularly at managing poor behaviour and are helpful in that regard. So the entry criteria will be children who have neurodevelopmental disorders and who have behavioural difficulties. And to define behavioural difficulties, we're using an instrument called the Child Behaviour Checklist. This is a tool which has been used in many different countries, 23 odd low and middle income countries to date, and I'll show you some of the data that we've on our pilot data that we've already got. And also the family needs to be committed to attending 10 weekly sessions over a 10-week period. The exclusion criteria are fairly self-explanatory. If there is a chronic medical condition that's going to, for example, chest infections, tuberculosis, things like that, that might impair prevent the child and the family being involved in the trial. So this is the Child Behaviour Checklist. We are actually conducting a separate study at the moment in Kilifi. This is it's a 100-item list which takes about 20 minutes to administer, and it has 7 behavioural components. The internal consistency is actually quite good for most of them, except for withdrawn, which is only 0.18. The retest reliability is also fairly good. The inter-rater is good between the mothers and the other caregivers, and those are normally the grandmothers or older siblings, but it's almost useless between the mothers and the fathers, which is perhaps not surprising. And the distribution scores in a completely random sample, this is actually a slightly younger age group than the one that we'll be looking at, from 1 to 6 years of age, suggests that a cut-off point of 50 would be a good cut-off point in order to identify children with severe behavioural problems. So we're planning to randomise by a central computer. We'll do it in blocks of 50 in each site to make sure that the between the intervention and non-intervention are equal. The non-intervention group will get standard care, which will include referring them to local services, occupational therapies, physiotherapy, and also some of the local organisations, for example, the Autism Society of Kenya, Cerebral Palsy Society of Kenya, and such like. The outcomes will be administered by the CBCL, and that will be again by field workers who are unaware whether the family has been involved in the intervention or not, so they'll be blinded in that context. And we'll be able to follow them up not only through the demographic surveillance, but also through the increasing mobile coverage that's occurring both in Kilifi and in Nairobi. The stepping stones P will be administered by practitioners. These will be actually drawn from the community. There'll be teachers, healthcare staff, and even some parents in some cases, those who can actually have a fair degree of literacy and who are judged to be able to administer the profile in terms of the stepping stones program, in terms of their language and communication. So they'll be interviewed. And the idea is to draw them from communities so that they will actually continue to remain in the community as we go on. In Kilifi, we have quite a low literacy rate compared to in Nairobi, and so a lot of it will be done by demonstration, either video or live demonstration, with active learning discussions, small group and individual exercises. There will be some written format, but it's less emphasis here in Kilifi. The sessions will take place in halls and schools, essentially away from the health facilities to try and prevent contamination, and will be delivered to groups of families of 5 to 10 families. This is the program. It's 10 weekly sessions I've already mentioned. The first 5 sessions are 2.5 hours each. The next 4 sessions are phoning up or making contact if they don't have phones to make sure that they're implementing the programming, the parenting advice, and then there's one final session to close out. The sample size that we have calculated is based on reducing quite severe behavioural problems from 50% down to 35%, and we think that we will probably get about 700 children, and so as you can see from the graph, we should have sufficient power to get effect sizes down to about 0.3 with between 80 and 90% power. I mean, we're fairly confident that we won't get many refusals because it's a non-intervention, a non-invasive intervention. So the primary outcome will be behaviour as measured by the CBCL. The secondary outcomes will be communication by the Communication Disability Profile, which is a tool that we've developed in Kilifi to measure communication in children with disabilities. We'll also look at parenting and quality of life for the families. And these tools will be assessed at 4 months after and 12 months after the onset of the intervention. And the primary endpoint is actually at the 12 months because we want to make sure it's sustainable in that context. We will have a full economic evaluation, which I'll come back to a bit later. The analysis will be intention to treat. The covariates that we're thinking at this stage of looking at are the site, the diagnosis, for example, whether it's autism, the degree of intellectual disability, the severity of impairment, the age of the child, and the maternal education. We're not planning to do an interim analysis because that wouldn't influence us to stop the trial prematurely. So the 2 big risks to the trial are really to ensure fidelity of the intervention and avoid contamination. So to ensure fidelity, we're going to have a detailed protocol adherence checklists, which we completed by not only the independent observers, but also by the practitioners. And we'll look at the relationship between the two. And we're also considering whether to introduce text messages to try and improve the fidelity. The contamination is the other major issue. The practitioners will only interact with the intervention group, and so that's going to be we're going to have to carefully control for that, particularly with the healthcare staff. We're not so worried about the teachers and about the other people, but the healthcare staff are the ones going to be quite difficult. We will conduct the sessions away from the health facilities, and we'll also ask, obviously, the parents, practitioners and families not to discuss the intervention for the year that the trial is conducted. In our previous trial of using women's groups to try and improve communication with children with disabilities, one of the problems that we got a lot of contamination. We did a randomized cluster design, but what happened was that all the women started talking to each other, as you would expect, which was great because, in fact, all the communication actually improved in both groups, but there was no difference between the intervention group and the non-intervention group. The major adverse events that we're concerned about are the mere fact of identifying a child with a neurodevelopmental process, given the cultural constructs around this, might lead to stigma, and that is a major concern. Also, the cost of treatment, so that the parents suddenly realise that they actually can get treatment for the epilepsy. How much is that going to cost the family in that context? There's also a danger of raising the expectations of the families. A lot of families with children, for example, with autism, think that autism can be cured, and will take the child around from many traditional healers, other health care services, expecting a cure, when in fact it's a condition which you can't cure, but you can manage. And then, of course, the loss of earnings, particularly in terms of attending sessions and also administering the program. We have specifically thought about convening a community impact assessment community, which will monitor the community's attitudes towards the trial, particularly the stigma associated with identification, and will consist of a social scientists, anaesthetists, and community representatives, and there'll be one in each site in the sites that we're involved in. We also are going to collect data to try and measure the amount of contamination that may occur, and also the reasons why the trial might not work. And this will be both through quantitative and also qualitative. We do quite a lot of qualitative work in terms of development of the trial, but we'll also do it afterwards to find out what the community's perceptions of the trial were. So we have a number of committees for the trial. These are fairly standard committees, and each of them will have their respective functions. And we contacted Trudy some time ago, and so she very kindly offered to give us a lot of support, and these are the sort of things that she suggested that the network would be able to help us with, and this will be very crucial to us because of the multi-site nature of it, as well as to have independent and experienced trialists on board. So the economic evaluation is really going to be centred around cost of illness of the disability, in terms of what the intervention will cost in the context of disposable income. This will vary between Nairobi and Kilifi, and also what will be the cost of sustaining the programme on a long-term basis. It's a fairly standard procedure. We've done it for other disorders such as epilepsy. We'll develop a cost inventory which will consist of both direct costs, direct medical costs, and indirect medical costs. Indirect costs such as loss of their earnings from parents, and also the one that's really always exercises us is the intangible costs, the cost of stigma, disfigurement, and loss of function. In the West, there's been a move in terms of context of willingness to pay to try and address some of these intangible costs, but this hasn't been explored in low-resource countries, and it's something that we're thinking about, but we're not entirely sure what the mechanism would be at this stage. We will, of course, obviously measure the resource use as part of the cost analysis, and then we'll be able to provide a fairly detailed costing of the intervention, and this will be done in collaboration with Judith Simon, who's an economist who does quite a lot of work on interventions in mental health. So the major questions that I would like to ask you before you ask me questions or to ask you to think about is, are there any things that we can use to improve the fidelity of the trial? What other measures can we use to reduce the contamination? And are there any other potential side effects that you can think of that we may not have thought about and that we should be addressing at this stage? And I think the last slide is just all the collaborators that are involved right across the UK and internationally. I'll leave those questions up. Thank you.